This episode is powered by Empowder. Mother Nature and modern science combine to create supplements that nourish your unique biochemistry.
Every section of society probably could name like the clitoris and the vagina without actually probably knowing what the anatomy is, but yet the shame around that, and we all come from a vagina, just so you know that is true. And yet the shame of that is perpetuated again and again, and that goes leaps and bounds into medicine, the practice that I do. And actually 51% of the population are affected by it. And I often say, if men bled out of their penis, would we have the same reaction? Probably not.
Hello and welcome to Women and Wellbeing with me, Natalie Anderson. In today's episode, we are unpacking women's reproductive health with specialist GP and medical broadcaster, Dr Nighat Arif. So sit back, relax, and get ready to join us in our conversation.
I'm a mother to 3 boys. I haven't been blessed with daughters. And I just thought to myself, I need to give something to my boys that when mum inevitably goes to a home, that they realise that mummy's vaginal estrogen needs to go with her. And that is the God honest truth, because
I wasn't expecting that in this conversation.
It's true. Like, honestly, I'm not going to hide it anymore. Like, I'm a 41-year-old perimenopausal woman.
Hello all, I hope you're all well. Today I am so excited to be joined by a lady who's been on my wish list for this podcast for absolutely years. A practicing GP specialising in women's health and family planning, she has over 15 years of experience in the NHS and private practice. A notable contributor to Davina McCall's Sex, Lies and the Menopause documentary, she's the TV doctor who's making it her mission to educate and empower women with regards to their health and well-being, using social media as a tool to break down barriers and bust the myths. I am super excited to finally have us join us. She is the wonderful Dr Nighat Arif. Hello!
Hello, thank you so much for having me. I also had a fangirl moment, just so you know, before I came in. I was like, oh my God, I've watched you for so long.
Stop it. Honestly, no, I am so thrilled to finally get you on our sofa. Like I said, for years and years, I have watched you, I have listened to you, been inspired by you, and I'm just so grateful to you giving us your time because, you know, I'll be honest, I first spotted you on social media, probably back in the pandemic when you were talking about the vaccines and how important all of that was. But then when you started talking about women's health and you were talking about it in a way that I felt nobody else was, I mean, what made you do that? What made you kind of take that leap?
I'll let you into a little secret because it was actually a dare by my sister.
Really?
It was never meant to become anything. The pandemic hit and I'm a jobbing GP. I'm a mother to 3 boys. My middle son was shielding. So back in the days, if anyone remembers shielding, my middle son has had a liver transplant. And so he's immunocompromised. This virus was coming around. None of us knew what it meant. And unfortunately, and now we know, as lots of people do know, that there was a lack of PPE. We were all very, very scared of what that meant for the vulnerable groups. So I tried to make it work that I could go into the GP surgery and see my patients. Everything changed overnight. We were now doing telephone and video consultations. Patients weren't coming into the general practice building setting. So I was doing all of that from home with my son, shielding with him. And at that time, TikTok was just crazy.
Yeah.
People were posting stuff they were doing at home. And I was having the same conversation about women's health, endometriosis, menopause, dry vaginas, everything you can imagine, but from home. And my husband, I think, firstly got an insight of what I actually do, even though we've been married nearly 18 years. And my sister, who's a dentist, her work just completely stopped. So we were talking to each other and I just said to her, do you know what, I'd really like to make videos about women's health, but stuff that I am literally doing every day to one person, I think lots of people will be interested. And she just went, oh my God, don't you dare do it. Because what will Dad think? I should just also caveat, my father is a priest. So it doesn't go down well that the imam's daughter is talking about the most taboo subjects. And I was just like, oh, but I think even if 5 people have a look, it'll be good. She goes, no one's going to watch it and it won't happen. I put out my first video about vulval vaginal atrophy in Punjabi and English. So I had to find the words in my language, like really dig deep into the language that I speak every day of how I can convey this through. And it just went bananas. It just went viral because what I'd realized with those videos were being downloaded by family members who are also home, who probably don't speak the language, and were showing it to their mothers, their aunts, their grandmothers, and going, oh my God, there's a woman with a hijab talking about this. And also, I think you might have this, and she's saying that this is treatable, which it is on the NHS and, the evidence-based medicine. And so it started off as a dare.
Oh, I'm so glad that you absolutely had the courage to just go and do it and go, right, well, fair enough.
I was petrified because I was really scared about whether it's going to come across, because I think I'm a quite quirky character.
Yeah.
Like I have a sense of humour about things, and I'm very serious about my medicine.
You definitely have a sense of humour.
I think that there's just so much stuff about women's health which is brushed under the carpet, which actually, most of society know. Like I often say, men know we bleed, women know women bleed. Every section of society probably could name like the clitoris and the vagina without actually probably knowing what the anatomy is. But yet the shame around that, and we all come from a vagina, just so you know that is true. And yet the shame of that is perpetuated again and again, and that goes leaps and bounds into medicine, the practice that I do. And actually 51% of the population are affected by it. And I often say, if men bled out of their penis, would we have the same reaction? Probably not, actually.
Probably not. And again, you taking that step to open up those conversations, those really, really vital conversations in women's health as well, that are often not being discussed in certain cultures or communities, and really getting to reach people. Like I said, I think that's for me what I first found within you, was that this woman is speaking to so many people that don't get the access to that education, or they don't have the conversations, or they don't have the vocabulary necessarily to talk about it, or they feel ashamed. They feel embarrassed by what's happening to their bodies. For me, that's kind of what really drew me to you. Was it a great response? Was there any backlash at all in the early days?
Oh, I got a lot of backlash. I think firstly, because at that time I was on like mainstream TV as well. So it was like Middle England woke up going, oh, there's a woman with a hijab talking about sort of women's health and the pain that inserting coils causes. And it was just like, I've always looked like this. Like I've never looked any different. So you get the obvious, I would say, racist, Islamophobic, misogynistic comments. And actually, I've just realized it's because there's an ignorance in the community where people don't realize that somebody exists, if that makes sense.
Yeah.
So I just thought, I'm going to lap it up. I'm going to wear the most colourful pink hijab with the most colourful dress.
Yeah.
Turn up in my kitchen with my cup of tea and talk about what I want to talk about. And then it's sort of gradually, then on social media, people found me. And on social media, it was very much like, again, that sort of shock and awe. But also realising, actually, this is really helpful. So I found my tribe through that. So the most powerful thing, which is now where I am at with my social media, is that I fit people into two camps. Ones that are just sussing me out, and that's fine because there's that level of trust. Is this person, quoting evidence-based data? Are they a registered doctor? Can I trust the evidence that they're that they're giving me? Can I go and take this, to my doctor? And the lovely thing is that I always get a lot of good response from fellow clinicians and doctors.
Yeah.
And I think that and I'm embarrassed to admit this, but I think a lot of people will feel like this. I get the most amount of reward when my contemporaries say, that was good.
I know that.
But you know that feeling, right?
do,
When your contemporaries say, yeah, Dr. Nighat, that was the OG, then you're like, oh, mate, I'm on it. And then I get another group of people who are just your tribe. They get your vibe. They're absolutely there. They're just as quirky. They want to learn more. They want to be empowered. They want to take that information and use it for themselves or give it to their community. And I always say that, if you learn something, let others light their candle in the knowledge that you've got. So whenever I put social media out, like it's never mine. That video is yours, Natalie, or whoever sees it. Like you don't even have to quote me on it. I don't want the credit. Just take it and run with it because that will teach your community. And then the third group of people who will still be there, who are entrenched in their ways. So I'll get the sort of women from my community who'll be like, sister, my husband came across your video about, painful sex. We're really embarrassed that you put this out. Can you just please keep these conversations behind closed doors? And I'm always like, now I ignore. I don't block. Right. I just ignore.
Yeah.
And I move on, or I delete, or whatever. But there was a time when I just thought, do you know what, mate? I think your husband probably learned something by watching this. But it's almost like packaged in a way that it's meant to be helpful to me.
Yeah.
So, and I think that, again, comes from their inability to look at the internalized misogyny that we still have, unfortunately, in certain cultures. But also, they know no different. That's the only thing that they've ever learned. Put it underneath the carpet.
Yeah.
So in Punjabi, we say, kapde de niche rakhna, which is a phrase which a lot of Punjabi people will probably hear, but it just means, make sure it's under the veil. Put this under the carpet, put it under the veil. And that somehow seems to uphold standards. But the problem is that when you're hemorrhaging underneath that veil, society will see that hemorrhage at some point. So isn't it better to stem it at that point? And if I can help with that. So there are a lot of people who are coming round to that, and then they transcend through those three categories, as I said.
I mean, like I say, the fact that, you have chosen to do that and you have had the reaction that you've had, you've now created this incredible book, which you actually released in 2023, The Knowledge, which I think is absolutely incredible. It's like it acts as like a women's health Bible that takes you through 3 stages. So you've got puberty, your fertility years, and then peri and menopause years. And the fact that there is this book that we can now have, and you can have it from being a preteen right up into to being an older woman, is so incredible. What made you kind of go down that avenue and create the book?
It was really for selfish reasons. I'm a mother to 3 boys. I haven't been blessed with daughters. And I just thought to myself, I need to give something to my boys that when mum inevitably goes to a home, that they realise that mummy's vaginal estrogen needs to go with her. And that is the God honest truth. Because
I wasn't expecting that in this conversation.
It's true. Like, honestly, I'm not going to hide it anymore. Like, I'm a 41-year-old perimenopausal woman. And the reason I made that book was because it was stuff that I deal with. It's my bread and butter, day in, day out. I get 10 minutes per patient. The NHS is a grueling place. It's a tough place. And with each consultation, it's like being a driver and having to gear change constantly. So when you're gear changing constantly, it's exhausting. So we get massive burnout at the end of it as GPs. And there's lots of other other issues within the NHS, which I won't labour the point with today. But I thought, wouldn't it be nice to have my women, the women that I look after day in, day out, which I have done. This August will be 19 years of service within the NHS. And they come in prepared. And also, I want everybody involved in that. I want women of colour. When I was a medical student, I just never saw me, like women with my skin tone. So I don't know what a lot of vulval skin tissues look like. So what does vulval lichen sclerosis look like? What does vaginal atrophy look like on black and brown skin? So we miss these women, or we shame them further by saying it's an STD when it actually isn't. But also, what do we do when it comes to Ramadan? There are no guidelines within the Menopause Society or the RCOG guidelines, which is the guidelines that we use as doctors to practice with our patients. So what to do with hormone replacement therapy. So I was the first one that wrote that with my father. And also, what do we do about sort of trans men and their health? Because that is massively underserviced at the moment. And so I wanted to incorporate that without shame, without taboo. And I just sort of wanted to hold up a mirror to the group of patients that I look after and say to them, you belong, and I see you, and I recognize the pain that you experience, and I wanted to cover that in my book. So when the lovely publishers at Hachette and Octopus contacted me, and they said, would you write a book? The first conversation I had with my publisher then was, I really need a black vulva, if that's okay. And she just went, really? And I went, yes, and it has to take up the whole page.
Yeah.
And that conversation of getting that pigmentation into the book was a number of conversations. And it meant that there was lots of sort of conversations that said, oh, could we just have line drawings and then just the markers coming out of it? And I realized it because it costs less, the less pigmentation you use.
Yeah.
So having pale or no color is cheaper. But then that means you're just massively taking out 13% of the population, which are from, ethnic minority communities. And I just thought, no. And luckily, my publishers were so on board. They could see the vision. And the book came to be as it is. We've outsold all our orders, and now it's going to be split up into 3 separate books.
Amazing.
As paperbacks. So I'm very, very proud of how it's just grown and grown. And again, find its own tribe.
And how it acts like as this thing, this book that you can pass around, you can give to different people, like at different ages, intergenerational conversations, which is so important, so massively important in women's health. I mean, if I can almost get you into a clinic idea, because I had lots of questions for different kind of conditions that people have. If we can look at a few of those, if you don't mind, is one of the big conversations I think at the minute that people are having is PMS and PMDD and how that presents itself. What's the difference? Can you just explain that? Because I know, for me personally, I know in my own cycle, there's definitely parts of it that I feel, really, really low, really down. But there is a difference, isn't there, for when you've got PMDD? Yeah.
So there is a difference between PMS and PMDD. Premenstrual syndrome, actually, we're not too sure. There's going to be a lot of conversations that I'll have with you where I'll say we're not too sure. But we think it's due to the rise and fall of hormones, particularly estrogen and progesterone as well. But we know that these hormones also interplay with our testosterone hormones, our melatonin, which is our sleep hormone. So PMS, we think that there are mild symptoms a week to 10 days before your periods, where you're in the luteal phase. So that's just as the estrogen's decreasing. You haven't fallen pregnant because the egg hasn't been fertilized. And as that estrogen decreases, causes low mood, irritability. You might crave a bit of sugar. You might feel a bit cold as well. You might find that your hair's just not such great quality at that time, and you might just get irritability and anger. PMDD is different. It's premenstrual dysphoric disorder. And we think it affects about 8% of the female population or non-binary. And we know that with that condition, it's not just the rise and fall of hormones. There's a fantastic couple of studies, although there's very few studies, which showed that the rise and fall of estrogen is one thing, but also with PMDD, it actually causes the neurophysiology in the brain. Isn't that so clever?
Yeah, wow.
That our hormones actually affect the nerves and the way that the neurotransmitters talk to each other in our brain.
Wow.
We now know that the brain is very neuroplastic, and that's because we looked at studies in pregnant women, hence why that brain fog pregnancy brain that we talk about. It's because of that. But we know with PMDD, about 2 weeks before your cycle, you get all over body symptoms, but particularly you get physical symptoms, shoulder pain, breast pain, aches and pains. Your hands and feet can feel quite cold. You might get digestive issues where you're feeling a bit bloated as well. You might also find that you're getting lower back pain as well. But then you get psychological symptoms, so irritability, rage, anger, tearfulness. You become paranoid to the point where you start sort of voicing that to the people around you, and you're just thinking that everybody's against you. You might sleep a lot more. You might not sleep at all. And also, the worst case scenario with your low mood and your depression and your anxiety, patients feel suicidal. It's that serious.
Yeah.
And then as soon as the period happens, that's it. It's like a light switch goes off and they're back to normal. That is the difference between PMDD and PMS. That's why we misdiagnose so many women, because we downplay the symptoms of PMDD and go, oh, don't worry, it's just your hormones, love. And here's, have a cup of tea and something. But it's not. PMDD is a serious, life-threatening condition. And the thing is that PMDD was actually not recognized as a gynecological condition. Get this, up until 2022. It took the World Health Organization till 2019 to recognize it as a gynecological condition, because before that, it was actually seen as a psychiatric disorder. So there are stories of women being sectioned, women being put on sort of untrialed, untested antipsychotics. Women, just because nobody had made that link between the fact that actually our hormones do play an interaction with our brain and our neurotransmitters. So it took us that long. So we've got a lot of catching up to do.
Definitely. And then if you think about the women in history, how they've been treated.
Lobotomies, ECT, all of these conditions. And, we have done a massive disservice to women's health, and we've got to do better.
I've seen in a certain space conversations around hysterectomies. Women are saying, I feel like that's my only option for PMDD, is to kind of have everything removed. And I mean, what's your take on that?
So let's look at the data first when it comes to having a hysterectomy, particularly if you're managing PMDD. If you're managing PMDD, then it makes no sense to leave the ovaries behind.
Right.
Remember, our adrenal gland in the brain. So a lot of the menstrual cycle is all actually controlled by the brain.
Right.
And then the ovaries. And then the uterus, because the lining comes away. And so if you're going to have a hysterectomy, it's usually the last stage of that treatment. But is it a cure? I don't believe it is. No. So we haven't got enough studies to show it cures your PMDD. What it does seem to show is that it reduces the highs and lows possibly, but also that monthly bleed that you get as well. However, by having your ovaries removed, it then pushes you straight into what's known as surgical menopause.
Yeah.
So I have got some patients. My youngest patient that has had a hysterectomy because of her PMDD. She also had fibroids and she had a few other complex issues. So the decision was made that she's finished her family and she's got 2 beautiful children. And so at the age of 32, she had her womb and her ovaries removed. And actually, it's now put her into surgical menopause. Not on the end of the world, because as a menopause specialist, I could look after that and support her with that. But it means that she is able to manage just the bleed, but some of the other conditions also need their own level of management as well. The goal should always be trying to manage someone medically before we have to get to a surgical option. So this is where I'm going to put my personal stance on it.
Yeah.
As someone who's been doing this for a while, I believe that offering a woman hysterectomy is because there's been a failure of medical management. And you can say that for endometriosis, adenomyosis. You can say that a lot for gynecological condition. It seems to be on the table, here, have a hysterectomy. And it's because we lack so many medical treatments. Whereas if I compare it to, say, other conditions, so let's talk about sort of cardiac problems, heart attacks.
Yeah.
Actually, if you look at it, I know it's apples and oranges, but we would never sort of do surgical management. We would do the nth degree.
Everything you could not to.
Exactly.
Yeah.
Everything that we could do not to before we start tinkering with it medically.
Yeah.
In regards, in regards to surgical treatments. And the same for, say, a lot of conditions when it comes to skeletal. We wouldn't just say, we'll chop off your leg just because now paracetamol didn't work.
Yeah.
But unfortunately, we do that for so many women's health, and it's just seen as a get out clause. And so I stand by my statement that it's a failure of medical management. So what we should be doing is developing medical managements first, researching that, and then having that. But at the moment, as it stands in 2025, hysterectomy is still on our table, but it doesn't cure it, it just manages the symptoms.
And are there any other options for women that are suffering, before they reach that stage? What can they do? Where can they go? What help can they get?
There is data to suggest that early symptom control would be really good.
Yeah.
But firstly, early recognition of that as well.
Right.
So women have to become their own detectives.
Right.
Again, talking about periods is so
Yes.
taboo within the household, but also we now know that there might be some genetic links as well. So let's talk about PMDD. If you're looking at that, you might not notice that the symptoms are related to your period. So cycle tracking is so vitally important. Then understanding what is the norm for you.
Yeah.
And then after that, at the moment, the first line treatments are for PMDD particularly. We sort of offer either hormonal birth control or we offer antidepressants. Now, before anyone listening to the podcast goes, oh my God, that's awful. They're not actually that awful, because we know that the data works really well for what's known as cyclical antidepressants. So we don't use the antidepressants in the same doses as we would for depression.
Right.
So for PMDD particularly, although we don't have any national guidance or anything like that, but from experience and from a lot of the data across the world has shown that if you give cyclical, so a week to 10 days before your bleed, if you can track that quite well, then it'll be a good idea to give somebody an antidepressant, so an SSRI, for example. And then you take it after your bleed, and then after your bleed, you stop them, and then the whole process starts again. And that's because at low dose, it seems to work really well for some patients. For some patients, then they can work out whether they actually need it continuously as well, because it overlaps so much with depression. Then hormonal birth control, there are two ways. Either you could switch off the ovaries or actually just stop the cycle itself. So long-acting reversible contraceptions work really well. And it seems to be that the ones where you've got estrogen and progesterone in them, so the combined oral contraceptive pill can work. And then obviously something like an IUS, so intrauterine device like a Mirena coil or 52 milligram levonorgestrel coil can quite well work, because what it can do is stop your periods. However, what we don't know yet is, because it hasn't been trialled and peer reviewed yet, is whether it does manage the PMDD symptoms. So for a lot of patients, a combination of that antidepressants and hormonal birth control, bearing in mind hormonal birth control can sometimes make psychological symptoms worse for some patients. So you've got to find the right one. And sometimes the first line treatment that you use might not be the one. So we go to others, we go to different types of progestrogens. We now have a medication which works quite well on our patients, which is called desprononin, but SLIND. SLIND is a type of progesterone, so it's a synthetic progestogen, and doesn't seem to have that level of impact on the brain and psychological symptoms. Doesn't cause acne with a lot of progesterone-only type of pills, doesn't make you put on weight or get fluid retention, doesn't make you bloated. So it is so nuanced that you have to individualize it to each patient. There's a great data for cognitive behavioral therapy as well, so CBT, great data for nutrition. And we know that nutrition plays a huge part because our gut is very close to where our womb is. So looking at sort of, foods that don't cause that much inflammation, alcohol, smoking, that's going to impact you. If you have a poor diet, that's going to be poor on your gut. That's going to be poor on your mental health as well. And then looking at restorative sleep. So when we're talking about well-being, we cannot miss the benefit of restorative sleep. The problem that we have is that we've normalized not sleeping well. So much. We've got devices, etc., that keep us awake at night as well. The blue light, the way that it impacts our brains. So when we talk about sort of wellness, we always focus on nutrition and exercise, but we never focus on sleep.
And sleep is so important for me.
Absolutely. Restorative sleep is so important for a healthy well-being, for our brain health particularly if you are predisposed to sort of getting PMS or PMDD or any other menstrual cycle symptoms as well. So I always say underpinning it all has to be a holistic approach.
And going back to kind of what you were saying earlier about the Mirena coil, I've had a few conversations with different women about, I think some women are frightened about the insertion of the coil because they've said it can be so painful and sometimes the pain is overlooked or it's minimized whenever they've discussed it with somebody. If you can talk me through kind of that insertion process, and also if you have experienced any pain, but that is an option for you, what should you be telling your doctor? Like what, that's 1,000,001 questions at you all at once. I'm sorry, but, kind of if you could just take me through that process.
Yeah, so a coil insertion always involves 2 appointments.
Right.
And anyone that's been trained by the Faculty of Reproductive and Sexual Health, such as I have, we've got very clear guidance on pain relief options. Firstly, if someone says they don't have pain relief in their clinic, do not get your coil from that clinic like that. You are not fit for purpose. And I know that lots of women have said that on my social media post and vocalized it, that they were offered nothing or not even told. And fundamentally, any invasive cervical procedure, such as a hysteroscopy or a coil insertion, you need to have pain relief to hand. So even before you get to a coil insertion, those 2 appointments are vitally important. So the first appointment is to work out which coil you want, a non-hormonal one or a hormonal one. So they will have their own side effects and their differences. Rule out any other things that might be going on, etc., and examine you at that time to look at your vulval vaginal skin. Do you have vulval lichen sclerosis? That could actually be really painful to insert a speculum in. Do you have any vaginal atrophy? So women as young as sort of 38 can get it, but also breastfeeding women, we also know that you can get what's known as genitourinary syndrome of lactation. So the vaginal tissue loses its estrogen, so it becomes very dry, and that can make it really difficult to put a speculum in. Also, that appointment allows the clinician to work out what type of speculum, how big we need it, what's the length, etc., and where the uterus is sitting. Is it sitting anteverted or retroverted?
You were talking to me about this. Retroverted, yeah.
Exactly. So I've got my pelvis.
Yeah, show me. I think I've got a retroverted.
Have you got a retroverted?
I think so.
Okay. So imagine being left-handed and right-handed. We know about 80% of the population are going to be about right-handed. Yeah, we know that.
Yeah.
So that's the same as anteverted. Anteverted just means the way that the position of your womb sitting. So the womb either sits a little bit forward, and about 80% of the population, because actually our womb is a dynamic organ.
Yeah.
It slightly moves around.
Yeah.
It's quite clever the way it does that.
Yeah.
And that's because in front of our womb is our bladder, which is a spongy organ which fills up just like a balloon or a Tesco's bag, I would imagine. And then behind it we have our rectum and then our bowel.
Yeah.
So this is actually quite dynamic. So an anteverted uterus will sit slightly forward. A retroverted means it sits slightly towards the back.
Yeah.
Because here you have your sacrum.
Yeah.
And so when we say it's retroverted, it means we need to use a specific type.
Yeah.
And that's just because 20% of the women have a retroverted uterus. In some women, it can mean that getting the cervix or the view of it might be tricky. So it's all about position. So you might have been asked to put your hands underneath your bottom to do a pelvic tilt. Yeah, that's it. And that pelvic tilt allows us just to see where the cervix is, and so we can use the right speculum for you. And then, even before you get to the appointment to have your coil insertion, 1 gram of paracetamol, okay, and then 400 milligrams, so a bit higher dose than you normally would do, of ibuprofen, if it's safe for you to have it. So you don't have a background history of asthma, or you're not allergic to ibuprofen, then you need to take that an hour before your appointment. When you get to the appointment, the positioning is so important. So position you on the right side, you will have sometimes I have nobody with me, sometimes I have a nurse, so it all depends. But then a choice of pain relief is quite important as well.
Yeah.
So we can use Instilla gel, which is sort of a local anesthetic gel. For some patients, it does nothing. For some patients, it actually brings them a bit of comfort as well. And this is another tip. Please take your own vaginal moisturizer with you as well. So if you know there's a moisturizer that works really well, take that along. And then we can offer a lidocaine or xylocaine spray, which is got local anesthetic in it. You spray it onto the cervix. You give it about 1 minute to 2 minutes and it works pretty quick. If that still doesn't get your pain under control and you're like, actually, this isn't so great, then we have what's known as a Cervi needle. So when you go to the dentist and they put that local anesthetic, it's a really, really, really fine needle. And you can put some local anesthetic into that. And that's even before you now start using any of the instruments.
Yeah.
So that is what the pain relief is available if it's just a wake, you're going into the GP surgery or the local sexual health centre to have your procedure. Obviously, if none of that works and you're not doing so great, then you can always opt to have it under general anaesthetic, but waiting for it on a general anaesthetic on the NHS takes a long time.
Yeah.
And general anaesthesia comes with its own risk. It's not a risk-free procedure itself. So we try and do that with calming sort of techniques, so breathing. So I get my patients to breathe in, and deep breath out, etc. Distraction techniques work quite well, but that doesn't mean that just hand holding and I don't use any anaesthetic. I definitely use anaesthetic.
I mean, oh gosh, you nearly made me want to cry. I'm not even going to lie to you when you were just talking about that then, because I just know so many women that have gone through so much pain and haven't been listened to. And to have somebody like you actually say, no, these things are on offer to you. I expect there'll be so many listeners that are like, well, I never knew that. And thank you so much for telling me that and for making me not feel stupid and for making somebody not feel, like they're or making them feel like they're weak or something. That I think that's such an incredible thing. So if in a practice, let's just say they haven't been offered pain relief, like you said, are they then best to kind of go to different practices and ask and say?
Yeah, absolutely. So in your local area, there'll be different sexual health clinics. So in some sexual health clinics, there's even gas and air. I forgot to mention that. So Entonox as well. And they never say you should use the NHS like a customer, but you are. That's the only way I can say it. You are the most important person and your pain is validated and we need to make you feel comfortable as well. And there'll be lots of people who will have actually very little pain. And there'll be some people who, we're all on a different spectrum.
Yeah, of course, yeah.
And you are well within your rights at the first appointment. That's why there's 2 appointments. At the first appointment to really pin down what pain relief that the clinician should be offering you. So if I take, I've been a Coil fitter for 12 years. So if I take my consultations, whether it's in the NHS or whether I do it privately, that still remains. That in my first consultation, I set aside about 20 minutes and I go through the whys and wherefores, the side effects. And then if it's not a telephone conversation and the patient's in front of me, I'll say, let me examine you and let me have a look. What are, so I can be prepared. And by the way, are there any things that I should know about? Are you allergic to any local anesthetic that you've ever had in the past? Is there anything that you think I should know? God forbid, has there been any sexual trauma that I should know about? That's even before you get to do the procedure. But I know that time is such a precious thing at the moment that some patients or some people do it all in one consultation.
Yeah.
And that's not actually a good thing to do. The other thing I think that we need to be really mindful of is that we need to get away from thinking that just because women bleed and women have babies, that they can tolerate pain.
Yes.
This is, I was going to swear, but I'm not going to swear. But the most flipping awful thing.
Oh, so we know the word she wanted to say.
Oh, yeah. But it just won't go away.
Yeah.
And we see this perpetuated more in Black and Asian. So the super strong Black woman,
Yeah.
Women can toughen it out.
Yeah.
And it's ridiculous. It's utterly ridiculous. And we can't seem to get away from that thinking or that logic.
Yeah.
And it wasn't long ago that there was actually a paper, would you believe it? This flipping awful paper. I'm not going to say. But you can guess the words I want to say. That actually said that the cervical ending, so in my other model, if I show you this, so this is the cervix right here.
Yeah.
So this opens up to about 10 centimeters when a woman is in labor. They said a paper that got published somehow got looked at by other healthcare professionals that said there's no nerve endings. I know.
Stop it.
I know. And it's just like, mate, what planet are we on that we are saying that this is okay? It's ridiculous. And we sort of do this perpetually. There are studies to constantly show that if a woman doesn't have children, that her risk of womb cancer or ovary cancer increases. I'm like, okay, fine. There are stuff and there's like science to back that up a little bit. But till this day, there's never been a paper published to say men who don't have children are at higher risk of prostate cancer.
Yeah.
If there was a like-for-like paper, then I'll be on board. I'll be like there every day going, oh, that's great. We've got a bit of like balance between what's happening with men. But we don't have that. We seem to think of women as these reproductive organs who can A, tolerate pain, who are these baby incubators, who have no nerve endings on their cervix. So why should we offer them birth control pain or even period control pain? And also, if they don't have children, shame.
Yeah.
You're at high risk of cancer. Mate, can I get that paper for Men's Health, please?
I mean, I know you're passive cross with Sarah Graham, who's absolutely brilliant, and her book Rebel Bodies, and she talks a lot about, kind of how we are like dumbed down in terms of women's health, and how like when you go for appointments, you're not getting necessarily, and depending on who your GP is as well, not everyone's as great as you are. Sometimes you'll get a GP who's kind of like, oh, you'll be all right, and it's old fashioned and old school. And we are having to put up with pain that we shouldn't have to put up with, and we haven't had this like for like kind of like education in terms of women's health and men's health, and how sadly lacking we are in women's health, and how far behind all the studies are. I mean, even just recently, and this will have to be like my last question, I wish I had more time, but I know that recently there was a link between autoimmune conditions and endometriosis. Yes. I mean, just talk to me about that, because it's like 3 years before you can even be properly seen for endometriosis.
The wait for endometriosis is awful. Endometriosis is not just a period. I've reframed how I say endometriosis is, because I think we need to not nullify the patients who suffer from endometriosis. Endometriosis is a lifelong, incurable, inflammatory condition where cells similar to the lining of the womb go outside into the abdomen, and it goes around the ovaries, the fallopian tubes, the bowel, the bladder. We've even found it in lung and in rare cases in brain. and it causes an impact on the immune system, particularly the macrophages, and thereby affecting the way that the immune system is able to regulate itself, but also causes attack on other organs within itself.
Yeah.
So therefore, we now realize that those that have endometriosis have other autoimmune condition, which, by the way, I just want to say women have said this for a long time.
Yeah.
So endometriosis sufferers have said this for ages and ages. We now have data from Oxford and Edinburgh University, which was funded by Wellbeing of Women, which is a charity that I'm an ambassador for. So it's amazing to finally have corroborated solid data. But also, it's just believe women.
Yeah.
Listen to them. And the fact that autoimmune conditions like MS, rheumatoid arthritis, osteoarthritis, Crohn's, celiac disease, fibromyalgia, psoriasis, they're all linked with endometriosis. So it's an all over full whole body disease. So why don't we have like other conditions where there is a full body disease? So let me take it, for example, type 2 diabetes is an all over full body disease. It's not just your sugars. We look after your eyes, we look after your feet.
Yes, so true, yeah.
And you get appointments to go and have a look. And then we also preempt other conditions like cardiovascular problems, heart attacks, strokes.
Yeah.
But for endometriosis, we have no quality outcome framework. So that means that if you're diagnosed with endometriosis, the onus is on you to be able to look out for it. And the good thing is this data that's come out only a week ago, the researchers said, hang on a minute, we need to treat this as a whole body disease and also preemptively look out for other autoimmune diseases so we can help prevent them or even manage them early on, because we know that if they're caught later, the disease has progressed. Let's take a rheumatoid arthritis. It's an autoimmune condition which causes inflammation of the joints. So don't leave it until someone is debilitated because their joint anatomy has changed so much that's when you're like, oh, by the way, you have this condition.
Yeah. We'll treat it now.
We'll treat it now. Thank you very much. So I think this is why it's so significant to go back to the whole sort of analogy of believe women when they say this.
Yeah.
We need to research far more. We need to have far more peer-reviewed data to look at it and corroborate it. And then also is to understand that these are not just gynecological diseases that are limited to our womb and our ovaries and how great we're going to be at reproducing things. Because endometriosis impacts our immunology, our hormones, our fertility, and our ability to live our life. So it can't just be a period.
Oh my gosh, honestly, I am so grateful that you've come today, because I just feel like we've all learned so much, and I'm so sad that we have run out of time, honestly, because you've been such an incredible guest, and I need you to come back now because there's so many more things, like literally I have papers and papers of things to talk about, and we've run out of time. But honestly, like, again, I just feel so grateful to have had you come and talk to our audience, to me. I feel like we've learned so much, and just to hear what it's like for you as well as a GP, and you kind of how you're, dealing with patients, and where you're, for you, how you're not supported in certain areas within your work, and what we need to do more, and what we need to lobby for and need to campaign for with regards to women's health. But yeah, thank you so much for being with me. It's been absolutely incredible. We have run out of time for today, guys. But if you'd like even more help from Nighat, then you can follow her on Instagram, where you'll be sure to get the best advice and maybe even a few laughs. You can find her at Dr Nighat Arif, and her brilliant book, The Knowledge, can also be found online and in all good bookshops. For more women's health and lifestyle, you can visit us at our website, www.thecapsule.co.uk. You can also catch up with our previous podcast episodes by visiting the podcast page and subscribing to any of our podcast channels and YouTube. Please feel free, as always, to leave your rates and reviews. It's been wonderful to hear from you as this series has gone on, so thank you for that. You can also drop us a message on our Instagram at Official Capsule if you'd like to put any questions to any future guests or leave any messages about any of our current episodes. But today, all that's left for us to say is goodbye. So it's goodbye from Nighat.
Goodbye.
And goodbye from me. And we won't be back next week because we are going on our summer break. That's right, everyone. We'll be back later on in the year, but I hope you've enjoyed being with us. Thank you so much to all of my incredible guests this season. I hope you've all enjoyed listening as well. Thanks so much to our amazing production team, to Kat, to Lavina, to Lewis, to Carleen. Thank you so much, everyone, for such a brilliant season. And so all that's left for us to say today is goodbye. Have a lovely summer, everyone. This episode was brought to you by Empowder. Mother Nature and modern science combine to create supplements that nourish your unique biochemistry.